Hi, Roman. It's wonderful to be speaking to you again. You and I first met during a certificate course at the Middlebury Institute of International Studies in Monterey, California, for their program on design, partnering, management, and innovation in 2017.
Hi, Larissa. Nice to see you too.
Hi, sorry. Hi.
Long time no see.
Yes. Your career has spanned over 2 decades of health systems reform, HIV/AIDS program leadership, and maternal and child health initiatives across Eastern Europe and Central Asia. From your early work with the American International Health Alliance introducing family practice in Russia to building integrated services for vulnerable groups with HealthRight International, to leading large-scale USAID-funded projects with Pact in Ukraine and IntraHealth International in Tajikistan, you've consistently worked at the intersection of policy, service delivery, and community health. More recently, you've also managed a 25-country HIV grant portfolio with the Elton John AIDS Foundation, giving you a rare dual perspective as both an implementing partner and a donor. Now, as a consultant, you continue to advise governments and organizations on public health strategy. I'm eager to learn today from your experiences and reflections.
Sure, I'll do my best.
Thank you. So the first question, what motivated you to pursue public health work in Eastern Europe, and how has your perspective on systems change evolved over the years?
So thank you. I think that I will need to start with a personal story. I was trained as a pediatric surgeon in Moscow, and during my training, I realized that as a practicing physician, I can reach only like a limited number of people, maybe several hundred a year, depending on the type of practice. Also, because of the oversupply of physicians in Russia, particularly in large cities, a surgeon like me would not be able to do any serious work before all those senior attending physicians and professors would retire or die out. So I started thinking where my efforts would be more effective and on a larger scale. And public health at that time, as it is known in the US, was new for the countries of the former Soviet Union. So in Soviet times, public health included sanitation and hygiene and health administration and some bureaucracy, and that's it. So I started researching on public health opportunities and got a scholarship from UC Berkeley, and that was the start of my public health career. And regarding the second half of your question on system changes, my understanding over the years evolved from this abstract WHO's 6 building blocks to like very practical application. And actually, back to the personal story, I did my public health master's thesis on physician oversupply in Russia. But what I can now say is that system changes sound scarier than it actually is. It is not a rocket science, but it's a hands-on process. System changes can be done at different scale, from one facility or one practice to global changes. And obviously, the effort depends on the scale. And the result usually does not look as neat and pretty as it was in the concept. But system change is the cornerstone of sustainability. So if the change is in the system, it is more likely to stay. And as a quick example, for instance, peer counseling or peer navigation for people living with HIV, if it is provided by an NGO as part of a grant, it is gone at the project's end. But if a peer counselor is a paid position on clinic staff, it is more likely to stay. And as almost everything in public health, system changes are very politicized. And as a US example, probably until recently, you probably never doubted that vaccines were here to stay. So that's my take on system changes.
Yeah, I picked up on you mentioning the WHO building blocks because that's actually something I have included into my global health course syllabus. So it's nice to see you tie that into your work, make that connection.
Good.
Thank you. I relate to so many of the things you said. The second question I have for you is, how did your work with HealthRight International shape your approach to integrating psychosocial support and primary health care for vulnerable populations?
Good question. And HealthRight, according to its name, operates on this rights-based premise that health is a human right for all, including the most vulnerable and marginalized populations. And our work in Russia and Ukraine, among others, concerned people who inject drugs, homeless, people in prisons, and migrants. So all those marginalized everywhere, including in the US. And to exercise this right to health, there may be two approaches, which in my mind are almost mutually exclusive. So one approach is public and loud advocacy, such as in mass media or social media, which is critical of the government. So, for example, at that time when I worked at HealthRight, there were health activist groups who were carrying coffins to the city governments in protest of the rampant AIDS deaths and unavailability of ART. It is perfectly legitimate activism, but it precludes constructive cooperation with authorities. Alternatively, you can do quiet advocacy with authorities combined with direct services to those in need to improve the health status of the most vulnerable. And the point is, if you're out and loud, you will not be able to really collaborate with the government. And at HealthRight, we exercised the second approach without being out and loud. And examples of success include keeping children born to women living with HIV in their families, instead of encouraging women to abandon the babies to state institutions, or providing drop-in center and halfway house services for street youth as part of government services, or providing CD4 count and viral load testing for people living with HIV in prisons by civilian health services, while ART was available from the prison system itself. So we were able to make some system changes by really collaborating with the government behind the scenes without loud advocacy. So I would say that's my kind of most important lesson learned at HealthRight.
Almost a fresh take in the way things are right now in a lot of other places in the world.
Yeah.
Great, thank you. The next question I have for you is leading the USAID Respond project in Ukraine. What was the biggest challenges and opportunities in scaling HIV/AIDS interventions?
So one of the new challenges for me was implementing a project that I did not design. So this is a common challenge at big NGOs when a grant writing team writes a proposal, and then a totally different team comes to implement the project if the proposal is funded. So from the start of this USAID Respond project in Ukraine, there was a disconnect between the expected results, which were the impact on the HIV epidemic in several regions of Ukraine, and the interventions planned within that project, which were behavior change communication intervention. And these interventions were maybe necessary, but not enough to make an impact on the epidemic. And then in 2015 came the biggest challenge, and at the same time, an opportunity. It's all in one. It was called PEPFAR 3.0 Pivot. So at that time, PEPFAR directed its partners away from scaling up behavioral interventions to very focused test and treat strategies targeting the most affected populations. For instance, sexual or injecting partners of people living with HIV, and the approach was called and is called index testing. So we had to completely redesign the project to implement strategies most effective to to achieve those global 90-90-90 targets. So the 90% of the estimated number of people living with HIV should know their HIV status. Those 90% of those who know their status should be on treatment, and 90% of those on treatment should be virally suppressed. So 18 months into that project, I got to redesign it and to continue implementing. So again, a couple of challenges, but a challenge and an opportunity in one.
Yeah. Thank you. Our next question. As chief of party for IntraHealth in Tajikistan, what lessons did you take away from managing a multi-sectoral program across maternal health, child health, nutrition, and WASH?
So again, it was a project that I did not design, and it also took a lot of my personal learning in nutrition and water sanitation and hygiene interventions, because I didn't know anything about them. And so in case you don't know what a VIP latrine is, it is a ventilated, improved pit latrine. And the project was building them by dozens for hospitals and schools in Tajikistan. So my point is here, do not shy away from new experience and new knowledge. And this cross-sectoral project in Tajikistan was the closest, in my experience, to the One Health approach, which included healthcare, food security, environment, which was water, sanitation, and hygiene, and this human-animal interaction, such as what's called the environmental enteropathy in young children when they are exposed to animal feces. And because this project was so comprehensive, it was exciting to work on, and it also brought real measurable and publishable results. The project also worked in very poor resource settings. It was implemented in 12 rural districts in 500 villages that covered 800,000 people at the border of Tajikistan and Afghanistan. And so volunteer community health workers were the best strategy to achieve results at scale on the community level. And at the end, we were able to even transfer this cadre of 1,800 community health workers under the government public health entity. Again, as a lesson learned, volunteer community health workers, a good strategy in poor resource settings at the community level.
Thank you. Next question is, having managed a 25-country HIV grant portfolio with the Elton John AIDS Foundation, what insights can you share about balancing donor priorities with local realities?
So actually, I think that this is an easy question, as in Eastern Europe and Central Asia, the Elton John AIDS Foundation relies on grant proposals written by local civil society organizations. So yes, the foundation has a broad framework in line with regional HIV epidemiology, but nobody at the foundation can be an expert on 25 diverse countries, different health systems, and different HIV epidemics. So the content of specific interventions funded by the foundation is defined by the applicants. The drawback of this approach is that the application's success very much depends on the applicant's grant writing capacity, so how they would be able to describe the needs and the changes they want to implement and how they want to implement them. So to make the competitions fairer, the foundation even offered grant writing workshops for applicants. So really the programming is driven by the applicants.
Yep. Okay, next question. In your experience, what role do NGOs and civil society organizations play in strengthening health systems in this region? And how can their impact be sustained?
This is probably the most loaded of all questions. As in Eastern Europe and Central Asia, the role of civil society and NGOs significantly decreased over the past 25 years. The situation may differ slightly from country to country, but the general trend is pretty much the same. So health-related NGOs used to be primarily funded by foreign donors, and be those government or non-government. And foreign funding went away from some countries whose income level improved over the years, but domestic funding did not kick in. I have an example of Bulgaria, which lost all of its harm reduction services for people who use drugs after the Global Fund left. In many other countries of the region, local governments are infringing on the civil society space in general, in fear of the civil society's influence on politics or traditional values or something else. And the shrinking civil society space squeezes out health NGOs, particularly those working with marginalized groups. And many countries also adopted what's called the foreign agent laws to squash foreign funding of political dissent, but also of the rights-based and anti-discrimination activities, which now prevents services for the most vulnerable. And sustaining any NGO impact is possible either through system changes, and that is by incorporating changes into government or private services, which is all but impossible with the shrinking civil society space. Or again, sustainability is possible through continued NGO funding. And with the decreasing funding, NGO impact in the region will be diminishing. So unfortunately, like what I've seen over the last 25 years and going into the future, in this region, the role of NGOs is likely to be decreasing.
I'm very familiar with the dependency on external donors and how that can put NGOs and others in a vulnerable position when those donors are no longer available, like now. But I hadn't really thought about the role of governments also kind of excluding NGOs, and they're sort of in this bad place from both directions.
Right.
Thank you for that perspective. Yes, did you want to say anything else about that?
No.
And I have one last question for you. This is more of a general question. What advice would you give to future public health leaders who want to work at the intersection of donors, governments, NGOs, and communities in complex systems?
All right. So I will allude to the current situation in international health. And one piece of advice is do not go there. That is international health just now. It is currently in ruins, and we need to see it start resurrecting and taking a new shape. For instance, under this recently released America First Global Health Strategy, and see where the global health goes from there. The other wise advice is getting cross-sectoral experience is greatly beneficial. For instance, getting a direct service experience before getting into the administration or the donor work will help you understand the other side and partners. And as I think I mentioned in one of my responses, just do not be afraid to dare, do not shy away from new knowledge or new experiences. So yeah. That's my little piece of advice.
Yeah, I think that's a great point, because the current situation, the current ambiguities, hopefully shouldn't make someone think, oh, I'm interested in international global health topics, but I'm not going to pursue it because it's too up in the air right now. They could instead focus on the skills that are needed, donor side information, learning about grants, learning about, I mean, obviously public health in general, all of these things. And when the dust settles, hopefully, there'll be more of a place for them to have a career in international health.
Exactly. I totally agree. And good luck to your students.
Yeah. Yes, thank you. And thank you so much for your time. I appreciate it so much. And it's really just nice to touch base and hear about what you're doing and also get a perspective from Central Asia. I don't think I said at the beginning that you're based in Almaty, Kazakhstan.
Yes.
So I think that will be interesting to share with people. And I think you have a really unique perspective. So thanks so much for your time.
You're welcome.
Okay, thank you. Bye, Roman.
Bye.